Another motor dysfunction disorder for which there might be a use for cannabis-based medicine is in Huntington's disease. This is an inherited genetic disorder that results in the death of brain cells, and there's also no cure for Huntington's. The earliest symptoms are issues with mood and mental capacity, depression, and then this leads to motor symptoms, so the inability to walk, talk and feed, and then will lead to dementia. The symptoms of Huntington's disease normally starts between 30 and 50 years of age, and it affects approximately 3 to 7 people per 100,000 people, specifically of European ancestry, because it is a strong genetic disorder. There is some clinical data on the potential of cannabis-based medicines in Huntington's. There was no effect of Sativex, so a small randomized controlled trial that looked at Sativex in 24 Huntington's patients found no improvement of symptoms with Sativex. Another small randomized controlled trial with cannabidiol, 10 mg per kg per day for 6 weeks, also found that there was no effect on the symptoms of Huntington's disease, and this was in 15 patients. But there was some positive effect of a pure THC product, nabilone, in another randomized controlled trial in 44 patients, and they found that THC at either 1 or 2 mg per day showed a significant improvement in total motor scores, chorea, which is the movement disorders in Huntington's disease, and improvements in cognition and behavior in the patients who took THC. There are currently no registered trials looking at cannabis-based medicines with Huntington's disease, so this isn't an active area of research. But there is strong preclinical data to think that we could use our knowledge about the role of cannabinoids and the endocannabinoid system in Huntington's in order to be able to manage symptoms. So both THC and CBD have been shown to be effective in animal models of Huntington's via activation of the CB1 and the CB2 receptors. And other phytocannabinoids such as cannabigerol, cannabinol and THCA have all been also shown to work in animal models. And it's also been shown that compounds that selectively activate the CB2 receptor, which has a strong anti-inflammatory action, also work in animal models. But there is a bit of a complication with Huntington's disease, because one of the issues is that the Huntington gene, which causes the disease, affects the transcription of the CB1 receptor. So what this means is that the Huntington gene prevents the CB1 receptor protein from being made, and so you end up having very low levels of the CB1 receptor in the brain. And because the CB1 receptor in the brain is so neuroprotective, it is thought that this probably contributes to the neurodegenerative aspect of Huntington's disease. And because there are low levels of the CB1 receptor in the brain, it means that giving something which is a CB1 agonist, such as THC, is not necessarily going to be effective, because the receptor that drug would normally bind to is downregulated. So I think unless you can find an alternative way of giving a phytocannabinoid that isn't working through the CB1 receptor, or you can find patients early enough in their disease progression that there is still enough CB1 receptor being expressed, I think it would be difficult to see a positive effect of THC or cannabis-based medicines in Huntington's. So what about Alzheimer's and dementia? This is another area that we have some evidence that cannabis-based medicines may be useful, from anecdote and from clinical trial data. Alzheimer's disease is a chronic neurodegenerative disorder that starts slowly and gets worse over time. It's associated with plaques forming in the brain, and it causes about 60 to 70% of all cases of dementia. The symptoms of Alzheimer's disease are memory problems, confusion, disorientation, problems with speech and language, personality changes, and low mood or anxiety. And Alzheimer's disease is typically most common in people over the age of 65 and affects about 30 million people worldwide. Dementia is the broader term for a group of related symptoms that are associated with an ongoing decline of brain function, of which Alzheimer's disease would be one of the forms of dementia. There are other forms of dementia. So the symptoms are very similar: decline in memory and ability to think, confusion and disorientation, agitation, personality changes, low mood and anxiety. And dementia, in the broader term, affects about 50 million people worldwide, of which 30 million people have Alzheimer's disease. So we have some clinical data on the use of cannabis-based medicines in Alzheimer's or dementia. Sometimes it's not specified which it is. So there's a randomized controlled trial, small trial in 15 patients that were given THC, and it was found that the patients had a significant improvement in body weight. So something that we're going to talk about in a couple of lectures' time is about the fact that cannabinoids can really stimulate appetite and eating. And so it may be because the THC is stimulating eating in these patients, or it can be that it's just not allowing them to forget that they haven't eaten. And there was also an improvement in their behaviour, so there was a less severity of disturbed behaviour in those dementia patients who were given THC. Another open label study. So what an open label study means is that all of the patients are aware of what they're getting. So it's not blinded. They know that they're getting THC, but then you record the data that you get with those patients. And this is an uncontrolled type of clinical trial. So an open label study in 6 dementia patients, 5 of whom had Alzheimer's, also found that dronabinol was effective at reducing agitation, aberrant motor, so motor dysfunction in these patients, and also disruptive nighttime behaviours. A cohort study, so this is another type of uncontrolled clinical trial, in 40 severely demented patients found that dronabinol was associated with decreases in all type in agitation, basically, and there was also significant improvements in the clinical global impression of change. So the clinicians ranked that the patients seemed better when they were taking dronabinol than they were when they weren't. And there was also improvements in sleep duration in the patients because they don't sleep very well. And again, the percentage of meals consumed during the treatment process period, which could be because of a stimulation of appetite or because they were more coherent and they remembered to eat. And nabilone, or THC, is still being pursued through active clinical trials that are registered at the moment. And specifically, this trial is looking at a reduction in agitation as the primary endpoint in Alzheimer's disease. So we also have quite a lot of preclinical literature to support the use of cannabinoids, and particularly THC, in Alzheimer's disease. Like in the other neurological disorders, THC has been shown to be neuroprotective through actions at both the CB1 and the CB2 receptor, decreases oxidative stress and inflammation and excitotoxicity. Again, these are all similar to what has been described for other neurological disorders. THC has been specifically shown to reduce cognitive defects and reduce memory defects in models of Alzheimer's and dementia, and there is a reduction in these plaques that form in the brain in Alzheimer's. It's not just THC that works, so other phytocannabinoids that have been shown to be effective in models of Alzheimer's include cannabigerol, cannabidivarin, and cannabichromine. So again, the future may look different in that we might find that one of these phytocannabinoids may be more worthwhile in pursuing clinically. So at this point, I wanted to mention the concept of ultra low dose THC. So in all of the neurological disorders, it's really THC that has been shown to be very effective, because THC is a CB1 agonist, and CB1 activation in the brain is very neuroprotective and can have a lot of beneficial effects in the brain. But it is quite dose dependent, and really the lower the dose, low dose THC will definitely have a better effect on the brain and neuroprotection than higher doses. And some researchers have gone even further and looked at what they call ultra low dose THC. So this is using a dose of THC which is far lower than that you would normally use. And I just need to stress that all of this data is still preclinical, so this isn't something that we have clinical data on yet. But it has been shown through a series of papers that ultra low dose THC, which is several orders of magnitude lower than that would typically be used, can protect animal models from the cognitive impairments caused by lots of different factors. So, for example, a drug called PTZ, which induces epilepsy in mice. It's been shown that ultra low dose THC can protect the brain from this detrimental drug. It's also been shown that ultra low dose THC can protect the brain against deep anesthesia or against the toxic effects of ecstasy, MDMA, or the toxic effects of carbon monoxide. So several different models of chemical insult that would normally cause brain damage or be neurodegenerative have been shown to be offset by ultra low dose THC. And finally, it's also been shown that ultra low dose THC can protect against age-related declines in cognitive function. So there is a natural decline in our brain function with age. There's nothing we can do about that. But ultra low dose THC in an animal model protected those animals from this natural age-related decline in brain function. So moving on now to some more behavioural disorders, we'll talk first about autism. So autism is a developmental disorder which is characterised by with difficulties in social interaction and communication, and by restricted and repetitive behaviour. And autism is a spectrum, which means that everybody with autism is different, and you can have very mild symptoms and you can also have very severe symptoms with extreme symptomology. So the various symptoms of autism include it being hard to communicate and interact with other people, and hard to understand how other people feel and think. They can find things overwhelming, so it could be lights or noises. They get anxious and upset quite easily with unfamiliar situations and social events. They can take longer to understand information, and they can do repetitive behaviour, doing the same thing over and over again. And autism is normally a childhood diagnosis, and about 1 in 50 children are diagnosed with autism or autism spectrum disorder. And this is a really upcoming area in terms of clinical use of cannabis-based medicines, and it's particularly surrounding the use of cannabidiol in autism. And this may stem partly from the use of cannabidiol in epilepsy, because autism is another childhood disorder, and because CBD was so effective in childhood epilepsy, I think that had an impact on the testing, the self-medication, people trying out CBD in autism disorder. And there is a recent review that has looked at all of the clinical data on the use of cannabis-based medicines in autism. So I'm going to use that systematic review to highlight to you some of the work that's been done in this area. So the systematic review, and remember I said in the first lecture or the second lecture, that you can use systematic reviews as trustworthy sources of evidence because they should have gone through the literature and found everything that was relevant in that particular area, which is why I've used this systematic review rather than my own analysis of the literature. So this systematic review found that there was 10 relevant published studies that had looked at the use of a cannabis-based medicine in autism. There were 3 retrospective and three prospective studies, so that's all observational data, 1 case report, which is also observational, and 3 randomized placebo-controlled trials in autism. The participants are mainly all children because autism is most prevalent in childhood. And the products that have been tested in these published clinical trials include cannabidiol, cannabidivarin, and various combinations of THC and CBD in a CBD dominant fashion. So similar to what's being used in epilepsy, these are either 20:1 or 50:1 ratios of CBD to THC. And some studies did look at THC itself or cannabis. And it looked at everything, or the studies have looked at everything from a single dose potentially affecting behaviour to 6 months of treatment. And the systematic review suggested, when they looked at all of the literature, that there is a beneficial effect of cannabis-based medicines or of these particular products on some of the symptoms associated with autism spectrum disorder, particularly the behavioural problems, the hyperactivity, and the sleep disorders with autism. And they did suggest that there was a lower number of side effects with the cannabis-based medicines than would be seen with traditional medicines used in autism. This is actually quite a research active area, and there are 9 ongoing trials on clinicaltrials.gov at the moment, which are looking at either CBDV, CBD, or a 20:1 combination of CBD to THC in patients with autism. So I think in the short to medium term future, we may find that CBD products, we have a much stronger evidence base, at least, for CBD or CBDV based products in autism, and potentially even the development of one of these products into something which is licensed and prescribable for patients with autism. So finally, attention deficit hyperactivity disorder, ADHD. So this is another childhood disorder for which people are looking at potentially using cannabis-based medicines, but specifically CBD. So ADHD is a brain disorder marked by an ongoing pattern of inattention and hyperactivity or hyperactivity impulsivity that interferes with normal functioning and development. And the symptoms of ADHD are getting distracted and having poor concentration and organizational skills, having impulsivity, interrupting and taking risks, and having hyperactivity, never seeming to slow down, talking and fidgeting, and having difficulty staying on task. And this is usually a childhood diagnosis, and about 3% of children are diagnosed as having ADHD, and this persists into adulthood in about 50% of cases. So we have anecdotal stories of a reduction in the symptoms associated with ADHD with cannabis, and there is also some clinical trial data. So there is a small placebo-controlled RCT in 30 adults with ADHD who found that Sativex treatment, so THC and CBD in a 1:1 combination, was associated with a significant improvement in the hyperactivity and impulsivity behaviours of these adults with ADHD. And there was also a trend towards an improvement in their inability to hold attention and for their emotional liability, so their unstable emotions. There was a trend for these to be improved also. There are currently, however, no trials registered trying to progress this data any further. So there's no ongoing activity looking at cannabis-based medicines in ADHD. So to summarize the evidence base that we have in terms of clinical and scientific evidence for the use of cannabis-based medicines in neurological disorders, let's go back to the hierarchy of evidence triangle and try and summarize some of what I've presented today to you in this and kind of rank them on this triangle. So in terms of the strongest evidence we can say that we have very strong evidence, meta-analyses and systematic reviews for the use of CBD in the reduction in seizures in childhood epilepsy. We can also say that we have very strong evidence for the use of Sativex in the reduction of spasticity in multiple sclerosis, possibly also in the reduction in pain in multiple sclerosis. And then kind of lower down on the ladder, we have some data that suggests, at least some early randomized control data that suggests that THC could be effective in a variety of neurological conditions, including Parkinson's and Alzheimer's, and also some evidence that CBD could be useful in the treatment of autism, and this is a very growing area. And then kind of lower down on the scale then is our evidence that cannabis-based medicines, and we don't quite know yet which products would be useful, but there is maybe some signal that a cannabis-based medicine could be useful in ADHD or Huntington's, although this isn't an area of active research at the moment. And just looking at that a different way, I've put the data into a table listing each of the conditions and those products for which we have best evidence and those products for which we have some evidence. So in epilepsy, our best evidence is that CBD is effective, although we have some evidence that CBD-rich products that have some element of THC might also be effective. In multiple sclerosis, the best evidence we have is that Sativex is effective, and then we also have some evidence that just pure THC is effective. In Parkinson's, we don't really have best evidence, but we have some evidence that either THC or CBD can be effective in the management of symptoms of Parkinson's, and similarly in Huntington's, we have some evidence that there might be a role for THC, although probably given quite early in the disease progression. In Alzheimer's and dementia, we have evidence that THC, and I think it's particularly important that we talk about low-dose THC, is effective in the management of symptoms associated with Alzheimer's and dementia. In autism, our best evidence so far comes for CBD being used in autism, although we have some evidence that there could be a benefit of CBDV or a CBD dominant product that had some THC in there also. And in ADHD, we have some evidence that Sativex could be beneficial at symptom management. But you can see that quite a lot of these neurological disorders really need more research to move some of these products from the some evidence column into the best evidence column. So in conclusion, we have high quality clinical data in epilepsy and in multiple sclerosis to support the use of cannabis-based medicines, particularly purified CBD or a THC-CBD combination. THC is still being pursued through active clinical research in both Parkinson's and Alzheimer's disease because of the strong protective effects of CB1 activation in neurological or neurodegenerative conditions. CBD dominant products or purified CBD are being examined for the management of autism, symptoms, and this is also quite a hot area of research. But our preclinical data shows us that actually many other phytocannabinoids are also effective in neurodegenerative disorders. So I would say watch this space in terms of this as a growing research area. We may find that some of these phytocannabinoids may end up in the clinic for the management of neurological disorders.